either raise your hands or shout out, or I'll try to follow, the chat as best I can. And let me tell you a little bit more about me. As Marty said, I spent most of my career at the University of Michigan School of Public Health, where I was teaching health law, public health policy, and the US healthcare system to mostly administrative and public policy students in healthcare, but also had a number of physicians who took my classes. And I've given lectures to physicians. I've taught the US healthcare system in Bayreuth, Germany, to University of Bayreuth students. And I taught at Charles University in Prague, Czech Republic, the same type of course. So I'm familiar with the needs of global students and what might help them better understand the US healthcare system. Most of my work was on the role of the courts in shaping health policy, but in recent years, I've spent a lot of time on the public health system and what works, what doesn't work in the US. During the COVID-19 pandemic, I've been very busy with public health legal issues around vaccine mandates, mask mandates, and other aspects of what health departments need to do to mitigate the pandemic. So with that as a bit of a background.
Can you make your screen bigger, Peter?
Yeah.
Okay. Where is it? Just so the slide fills the whole screen. We don't see the sidebars.
Okay, hold on. So
the bottom, I think on the bottom, one of those works.
that?
Yeah, great. Yeah, thank you. Good. Perfect.
Okay, very good. All right. So my objective is, let me see if I can get I got the chat box back up. So again, feel free to interrupt with questions. Marty, same with you. Feel free to clarify anything that you might think will be helpful to our friends in the cohort. My objective is to provide a general overview. I use this set of slides in my courses and then spend the rest in the first session or two, and then spend the rest of the time filling in all of the details. I'm not going to try to give you all of the details. Rather, my hope is you'll come away with a better understanding of how healthcare is structured and what some of the key issues are. And then as you work in the US, you will have a better sense of how what you're doing fits in with the overall system. And of course, the details you'll get on a day-to-day basis. So how is the US system structured, financed, and delivered? Hello? Is that a question? No. How is healthcare regulated at the state and federal levels? And here I should say, if you're not aware of this, and you'll have a similar structure in many of your countries, the US has what we call a federalist system. That is, it's equal sovereignty between the federal government, Congress, the president, the judicial branch, and the states. And the states are sovereign entities with plenary power to act in healthcare. For public health, most healthcare is provided at the local level, For healthcare, it's heavily regulated at the federal level by Congress and the executive branch. And then as we go along, think about how the US system compares to the healthcare delivery system in your own country. What are the relative strengths and weaknesses? And I found that the students in Bayreuth had a very different take than the students in Prague, and it was a very interesting set of discussions. Hold on, oh, I got it. All right. So some of the questions to think about during this session would be, what are the strengths and weaknesses of the US healthcare system? What changes would you make if you were a policymaker or if you were leading a physicians group? What changes would you want to see that would help physicians? That would would you replace anything? Would you make it a universal healthcare system, or would you make it a free market system entirely? As I'll suggest, we're headed toward the latter and away from healthcare as a universal right, but more as another business enterprise. Would you prefer being a patient in the US or in your own country? If the latter, which one and why? What are the criteria you would use to assess how well the US healthcare system or your own is working, and how, as I said, does it function in comparison to the system in your country? All right, so I like to start out with some what we might call organizing principles. And the first thing, and in some ways, the most important aspect is that the US healthcare system is a market-based, a free market-based system with heavy governmental oversight. And it's important here, again, to keep in mind that we've had numerous policy debates about moving toward universal health care, governmentally provided system relative to free enterprise. Right now, it seems to me that with the increasing amount of venture capital going into the healthcare system, that it's becoming more and more just another private sector operation. For example, if you walk into a public nonprofit hospital and a private for-profit hospital, you won't be able to tell which one is which. They operate the same. There's very little now to differentiate a for-profit hospital from a community-based nonprofit. I'll get back into that a little bit later. Our system is very complex to navigate, and I think you'll start to see that as we go through this. You have an array of different functions, all competing and not very coordinated. So, for instance, you have to get approval from your health insurance company for a procedure in most instances. You can't just walk into a surgeon's office and say, I want you to fix my nose. I don't like my nose, unless you want to pay. If you want to pay out of pocket your own money, that's fine. But if you're relying on insurance, the surgeon will first need a referral in most cases from a primary care physician. And then secondly, we'll want to know whether you're covered by insurance. Try finding out the price of that service, by the way. It's virtually impossible, even though hospitals are supposed to post their prices there's no uniform price. Each health insurer negotiates how much it will pay for that procedure, to fix my nose, and I won't have, it'll be a function of which insurance company I have and how much it will reimburse the physician. So from an ordinary patient who doesn't know the US healthcare system, it's maddeningly complex to navigate. It's very difficult. Most academics and commentators about the system like to say it's basically a non-system. A more systematic approach would be a governmentally provided system. One payer, one place to go for all information, and basically a national health system. That's not what we have. We have a decentralized system where the individual providers, the physicians or the hospitals, the health systems, nursing homes, pharmaceutical companies are all independent actors. There's no single point of accountability as a result. And in fact, quite the opposite, there's diffused responsibility. So if something goes wrong when I'm a patient, what happens is everyone tries to blame another actor in the system. Now, let's say, for example, I go in and have surgery, knee surgery. Let's say it doesn't go well and I have complications. I need and I have, let's say, an infection. So there's a lot of pressure for me to be discharged sooner rather than later because inpatient care is very expensive. Okay, there's a lot of pressure on you as my treating physician to do that, to discharge me. So what happens if I'm discharged too soon and have an adverse event? Either I have to return to the hospital or I have multi-organ system failure because of the infection. Is the physician to blame for the discharge? Is the health insurer to blame because the insurer put too much pressure on the physician to discharge the patient? Is the health system or hospital responsible because it allowed me to be discharged? So you can start to see that the dynamics here of blame. And this gets to a very fundamental factor in thinking about the US healthcare system. It's organized into separate sectors. There are hospitals, there are rehabilitation centers, there are nursing homes, there are private psychiatric hospitals, there are health insurers. They all operate independently. Physicians groups, most of them are for-profit. Nursing homes are almost all for-profit. Home health care agencies are almost all for-profit. Many hospitals are for-profit. Most physicians are for-profit, and we'll get to that a little bit later. There's rapid change. Many commentators like to say the healthcare system in the US is as stable now as it's going to be. In 10 years, it'll look very different. If I write about the involvement of venture capital, the growing involvement of venture capital, it will look very different. It will look much like any other business in the US. And it's the nonprofit status will be obsolete. One of the benefits of this whole non-system, though, is it's very innovative. It's very entrepreneurial. if you have a good idea, if you have an idea about online insurance that would facilitate the process, or if you have an idea about interoperability so that data from one insurer can be transferred easily to another, or one hospital to another hospital outside of a network, which we'll get into, you can get funding as a startup. You can be an effective and successful entrepreneur. There are barriers to entry, but look at what happened with telemedicine during COVID-19. I think that's going to be a major change in the system coming out of COVID-19, that more and more people will use telemedicine. I happen to think that's a good thing, but it took a pandemic to embed telemedicine in the psyche of both patients and physicians. That didn't work. As I said, it's a mix of profit and nonprofit. It's also a mix of public and private, in the sense that we have public funding that I'll come back to later through Medicare for the elderly and Medicaid for low-income system. And there are many sources of funding for people who can't afford to pay. Yet we still have roughly 15 to 17 million people without insurance. Some of that is voluntary. Some of those are young people who are healthy, who think they're invulnerable, but most of it is from low-wage workers who aren't covered, which reminds me that, I'm sure I'll come to this in the slides, but one of the reasons for why the system is structured as it is a relic from World War II. During the war, private businesses needed to attract workers. And one way they did it was to offer health insurance. What happened was this embedded the employer as the primary source of health insurance in the country, not the government providing healthcare. So out of the war, we had a building boom of hospital modernization and construction, in part because we learned a lot from battlefield medicine. And we started then after World War II to have the private pharmaceutical industry expand, particularly in the 1960s. And the government retained its focus on research through the National Institutes of Health. Meanwhile, employers after the war started building on the private insurance that had started in the 1930s with Blue Cross Blue Shield. And what the employers did was to offer employment benefits. We will pay, as part of your benefit package, your Blue Cross premiums. We'll negotiate with Blue Cross. So post-World War II, this system of employer-sponsored benefits with private insurance dominated. Harry Truman in 1948 tried to build a national healthcare system. It failed. Jimmy Carter in the 1970s tried to build a private insurance, a public universal healthcare program. It failed. Bill Clinton in the 1990s failed. And then we got the Affordable Care Act in the Obama administration, which has survived, but is hardly a universal healthcare system. It's a mix, as I mentioned, the state and federal responsibilities. Despite being a free market activity largely, healthcare is very heavily regulated at both the state and federal levels. The states have primary responsibility for licensure. So when you are working in a US hospital, the hospital or health system is licensed by the state. The physicians are licensed by the state. The quality of care is measured by the state. In contrast, the federal government heavily regulates Medicare and Medicaid because Medicare is a purely federal program. Medicaid, as we'll see, is a mixed state and federal program. But in some, there's no right to health care in the US. Unlike many of your systems that are national in scope, where everybody has an equal opportunity for healthcare, in the Czech Republic, for example, not the case in the United States. All right. So I want to go through a couple more conceptual slides and then stop and ask if there are any questions. In the US, we separate public health, disease prevention and mitigation from the healthcare, the medical care, from clinical care. The public health system, health departments, are publicly funded, but the funding for health departments has declined steadily. And we saw the damage done during COVID-19 with inadequate staffing and resources for public health to mitigate the spread of COVID-19. What I view as a potential future for healthcare is a combination, an integration of clinical care, particularly primary care, with public health. Public health is responsible for prevention, keeping the community healthy. Hospitals are under more pressure to invest in mechanisms and programs, initiatives to keep the community healthy. So I could see a merging of the two systems. But as I said, healthcare is largely a business enterprise. And that means that the role of the government changes. It changes from largely being a provider. If you have a national healthcare system, the government is a provider and an insurer. In the US, the government is largely a regulator and insurer through Medicare and Medicaid. But that leaves a lot of role for the government as over what we call competition policy. That is the nature of regulating the free enterprise system so that we don't have predatory pricing, we don't have monopolies. So we use tax policy to regulate healthcare. We use antitrust policy to control against excessive consolidation. But let me be clear, neither one of those policies, neither taxing nor antitrust, has slowed the trend toward a private sector that is consolidating rapidly. It's very difficult now for a physician to maintain a small independent practice. I spent the last couple of days, my wife and I had visiting her close friend who's a radiologist who's been maintaining a private practice in New York City. More and more radiologists are now healthcare employees. They're in hospitals like Mount Sinai, Beth Israel in New York. It's harder and harder. Linda's friend is on the verge of selling her practice because the consolidation of larger and larger healthcare systems and the venture capital buying up physician practices means that it's harder for physicians, for someone to come out, set up a practice, and survive. It can be done, but it's very difficult now. I'm having trouble. Okay, as I mentioned, it's largely an employer-based insurance system. That's why it's now so hard to move away from the current mess that we call healthcare, because nobody, the public, about 60% of the public is insured through their employer. Everyone's afraid to give that up. Everyone's afraid that the government will be less efficient, that the government will ration healthcare. The irony is that the Medicare system, which is a purely governmental system with some private sector offsets, is hugely popular. And so many people like me who are now on Medicare would be happy with the Medicare system. I'm also getting my healthcare through an integrated system, Kaiser Permanente, a managed, what we call managed care system. So it's increasingly consolidated, as I said, into larger and larger players. A majority of the nonprofit health hospitals in this country, I think, are already under the aegis of Catholic health systems. And that presents real problems for people who are interested in reproductive health, for example, because Catholic hospitals maintain strong controls over things like birth control, reproductive planning, abortion, and some religious strictures around gender dysmorphia. Our system is, the coordination of care in our system is highly fragmented. If you're in a managed care system, which I'll define later, your care is coordinated. But if you're relying on health insurance, you're going to a physician here, you're going to Dr. Stein for for therapy. You're going to Dr. Jacobson for your primary care. The two may or may not have compatible records. I may not be able to follow your trajectory because you're not in the same system. So there's lack of coordination. The emphasis is on volume, not value. We give lip service to what's the most valuable care to be provided, where there's a positive benefit to the care, as opposed to what we call, and I'll define this later, the fee-for-service system. Purely, you pay for what you get. So if that's the case, won't I try to get you to buy more of my service? If I'm paid on a per capita basis per individual patient, then my incentive is to provide you the least amount of care at the lowest level possible to keep you healthy, not to give you more procedures, not to give you another ultrasound or another MRI or CAT scan. Rather, it's to give you an X-ray until we see if you need something more. I'll come back to these points, but just for your own background, there are a lot of people who don't like the current system. And one of the major players in that area is the Institute for Healthcare Innovation, which developed its triple aim rubric or theory to improve the quality of care, improve the population's health, that is the health of the uninsured population, people in the community, and reducing the per capita costs of treatment. Notable goals, I think we've made minimal progress on quality of care, though I think quality is generally pretty high in the US anyway. Very little movement on improving the population's health for a lot of reasons, and virtually no movement in reducing costs, despite a 50-year effort to lower costs of care. Whoops. Hold on. Okay, that's better. All right. Any questions from anyone or observations?
Yeah, I have one question. What about assessment system for quality of healthcare? I mean, I have a friend in Germany, and he said that if patient in Germany have rehospitalization after primary hospitalization during the first 5 weeks, it will be a big problem for hospital because it will be free for patient and hospital will pay for it.
Right. Good point. There are a lot of people saying, by the way, that we would do better to emulate the German system, and particularly the way insurance is provided, because everyone pays the same rate. So you have to compete on quality and amenities and costs. To your specific point, there are incentives in the US, but they tend to be more demonstration programs. For example, there's a similar program about readmissions. If a patient is readmitted within a certain period of time, then the hospital is responsible for that care, not the health insurer, not Medicare, Medicaid, the public system, or the private health insurer. They've had, the studies have been shown mixed results. It mostly, it hasn't changed how the quality of care. It hasn't really punished hospitals sufficiently. It may be because the terms are not stringent enough. It may be because there just aren't, most readmissions are legitimate. I don't think we know the answer. In addition, there are all sorts of quality monitors in the US. There's at the individual hospital level, there's peer review, where your performance is measured at a minimum once every 3 years, and often every year. There's federal peer review for Medicare and quality assessments at both the state and federal level. Yet not much has changed. When I talk to people who do research in this area, there's this sense of frustration that we tried relying on patient assessment. Well, I can't really qualify your care. I'm not qualified to tell whether my infection, let's say after my knee surgery, to take the former example, is because you did a poor job, or the infection was because there was a problem at the hospital level, or neither, or that it's just there's a certain percentage of people who are going to be infected post-surgery. So it's a great point. I wish I had a better answer. There's a sense among researchers that progress has been at best incremental on quality and probably minimal, and that the the programs of trying to figure out how to sanction low quality have not changed very much. And in the US, one final point is that we tend to use litigation, the courts, to oversee quality of care in a very dysfunctional way. So let's say I have this adverse result, and because of the infection, I either have, let's say I have long-term disability, that my knee is now so damaged. What's going to happen is I will probably sue you, I'll hire an attorney, sue you and the hospital. Now probably will end up settling, but the idea then would be for the hospital to conduct an analysis to find out what went wrong. And if you think about that, it's very inefficient. What you, based on your question, the German example, is much more efficient if it were to work. It may be, I guess, it may be that the Germans are doing it more stringently, are really the insurers, because they can't charge more, are really imposing these quality metrics on the system. It's a good question. Thank you.
Thank you very much for your answer.
Other questions?
Any more questions? Please feel free to ask.
Yeah, don't be bashful.
Mhm.
And feel free to disagree. You wouldn't be the first people to disagree with me, by the way. Most of my students, I encourage to challenge me. All right, well, then let's move on to a different way of thinking about the system. Relative to the European Union countries, the US system is higher in cost, and this may not be fair, but I'll say it anyway, modest in quality relative to the EU countries. I think where we excel is in, no surprise, that highly specialized, highly technical care, that high cost tertiary care in academic medical centers, where we do probably a much worse job is with primary care. That day-to-day care that involves prevention, it involves access to the system. And as I mentioned, we still have a large number of people without health insurance who show up in the emergency departments, cost the hospital a lot of money, particularly hospitals serving low-income communities, with little, if any, reimbursement. And as a result, we've seen a continuing attrition in two areas, in the inner city urban areas with very low income populations, and rural areas. So we're seeing a lot of hospitals closing in rural areas for a lot of reasons, but including the fact that many people in rural areas don't have good insurance, and inner city urban areas with the high, yeah.
You point out that no matter, even if the patient has no money, the hospital emergency rooms are obliged to take the patient and
Yeah.
stabilize them.
Right.
They have to pay.
If you operate an emergency department and there's no requirement that you do, you can be a community access hospital without an emergency department. But under federal law, called the Emergency Medical Treatment and Labor Act, EMTALA, you're required to screen and stabilize a patient. You are not required to transfer that patient into your inpatient population, but you're not allowed to refer that patient to another hospital, what we call dumping, if the patient isn't stable. Once you stabilize the patient at your own cost, if the patient has no insurance or isn't eligible for a federal program like Medicaid, you can transfer that patient to a public hospital. But in a lot of cases, someone comes in with, let's say, with a serious gunshot wound. You may not be able to transfer. You may have to treat and keep the patient in the ICU or in an inpatient bed, as Dr. Stein points out, at your expense. So, as I mentioned, we've had these robust health policy debates, but there's no consensus. There's still no consensus at either the state or federal levels. It shouldn't surprise anyone that we have a culture of technology, and we think as a generalization about the US, we think that more technology is always better. It's not, but it's almost always initially more expensive, although over time, the costs tend to go down. There are real benefits to a culture of technology. As I said, for really exotic care, for rare disease, there's probably no better place to be for the most part than the US, but that comes at a cost. It's part of why our costs are so high. Think back to the way I talked about the fragmentation of care. Let's say Dr. Nokina, that's how you pronounce your name, sorry, operates a hospital in, let's say, Virginia. And Dr. Hu operates, he's sitting in Fairfax, Virginia, operates a competing hospital. Dr. Nokina gets a new instrument, the successor to a CT scan. And Dr. Hu sees his patients migrating. Well, he's going out tomorrow to get that new exotic technology, or else he faces a loss of revenue that's not sustainable. But who's paying for that technology? The insurers, the patients, well, most likely the employer through the insurer, but the costs go up. And that's how the culture of technology works. Maybe those machines are great, but do we need two of them in the same area? Now, we have had in the past what we call certificates of need, where you have to get permission from the state to buy that fancy equipment over a certain amount of money. But those have atrophied, and many see it as an intrusion on the free market. Let the free market work. That in theory, competition will drive the price down. Instead, in this example, it drives the price up. And that is a continuing problem in the US. As I mentioned earlier, the fee-for-service system provides incentives for more care. Fee-for-service is simple. It means I go to Dr. How do you pronounce it? Neofidov?
Neofidov.
No, Neofidov. I got this.
Yeah, that's right.
Neofidov. I go to Dr. Neofidov and I pay him a fee for his service. Now, if I'm in a managed care field system, which I am in Kaiser Permanente, I go to Dr. Stein, I may pay a copay, but I don't pay a fee. The fee I pay is my annual premium for all of my services. Whether I get 25 visits, I need to see specialists, it's all the same fee plus a copay. But if I go to Dr. Neofitov for one thing, and he refers me to let's say, Dr. Caval or Dr. Reno, I'm paying those, Dr. Reno or Dr. Caval, a fee. It's called a fee for service system. And it's no different than you go to buy a car in the US, you pay a fee, how much that car costs. The difference is in most global health systems, you don't pay a fee for the service. The fee for service drives volume. It doesn't drive value. Fragmentation I mentioned. Access. So two commentators, Alain Enthoven and Rick Cronin, term this a paradox of excess and deprivation. So we have too much healthcare for people who are wealthy and too little for those who are in the working class. Cost, quality, already, and we have enormous racial and ethnic disparities. There is no question that particularly African Americans don't trust, have considerable historical distrust of the healthcare system. And there's a lot of evidence demonstrating why that's quite rational and still continues today. And in fact, women have similar complaints because most research is conducted on men. There's a gender imbalance in how we conduct research. And I would encourage you to, as you spend time in the US, to look at some of the good sources of information that will help you understand the system. The Kaiser Family Foundation has a daily newsletter that you can skim to see what's happening in healthcare. And there are many others. The Commonwealth Fund. I encourage you to read papers like the New York Times, Wall Street Journal, and the Washington Post that have heavy coverage of healthcare. The Incidental Economist is a great blog. Health Affairs is a good institution. I like to refer people to also the market-oriented institutes. Cato is a libertarian think tank, American Enterprise Institute. There are lots of information sources. Okay, any questions before we get into the more granular part of the talk? Anything? Okay.
Sorry.
Yes.
I have a question.
Sure.
Thank you for the presentation. What do you think, which is better? I mean, system where every patient can choose his option. I mean, insurance plan depends on his income, or system where everyone can have the same healthcare, but quality of this healthcare is very low. I mean, you can see on to Russian system because every citizen can have the same healthcare, but quality of this healthcare is very low.
Yeah, it's an important question. Given what, and I answer this in part by relating how the students in Bayreuth answered that and the students in Prague. The students in Bayreuth said, if I have a rare disease, need high technical care, I'd rather be in the US. For primary care, I'd rather be in Germany. The students in the Czech Republic who were from all parts of Europe, but primarily from the Czech Republic and Slovak Republic, said, we prefer that everyone have access to care. I think the difference is that probably they felt the care in the Czech Republic was not of low quality. It was more of average quality. And I think the problem is if you're making the distinction between really poor quality and a free market system, I'll take the free market system with all of its flaws. But if you're talking about average quality, my bias is toward equity, where everyone has access, and you sacrifice something at the top, but in the long run, everybody is protected. You protect the community because you can prevent some of these diseases of what that we see in the US, of obesity, of smoking, the preventable diseases. So I think the way you frame it, I'd have to say I prefer access to choice. I mean, it's a good point. I probably should have built this in up front. But one of the advantages of the US system is you are free to choose. Although that's less so now because more and more the health insurers are establishing networks. And if you're in the network, you're fine. But if you go out of the network, then you have to pay more money. And it's very hard for an individual to know whether he or she is in network. But this idea of choice is a strength in the US system. You are free. If I don't like how you treated me, I can just go to Dr. Gregorian or Dr. Khan and see if I can do better that way. And so choice is fine, but choice only works in the US if I have the resources. There is no choice if I have no access. Trade-offs. So the real trade-offs here. How would you answer your own question?
My point of view is that choice is better than poor healthcare system without any opportunity to provide high quality or high technological care. I mean that I prefer complex healthcare system with opportunity for everyone, with different opportunities for everyone.
Right. So the ideal system is one where everyone has access, maybe a mix of public and private, so that everyone has access to good primary care, good secondary care. And maybe you just have a two-tiered system that I can go out and buy the higher quality technological care. It's a tough balance. It's tough to maintain. The U.S. has certainly not been able to do it. But let's suppose it's not poor quality care. It's good, average care with limited technological versus the free choice. Does that change your view?
Thank you very much.
Okay, good.
Dr.
Yes.
Jacobson, sorry for
Yes.
interruption. So while giving an answer to my colleague, you mentioned that these insurance companies are forming networks and patients do not have an idea if the provider, physician, or a healthcare system, or a hospital or a clinic is inside this network. So aren't there any lists or affiliations so that person can know if they go to the in-network provider or outside the network? Because in Georgia, where we have private insurers as well as this government-funded healthcare system, there is a list of hospitals and physicians who provide care inside the network.
That's what ought to happen. We've been very slow for reasons that I don't quite understand. Well, I do understand. It's about money. There's no incentive for the network to be
Reveal that
aggressive
because-
about because they don't care. If I go out of the network, I'm paying someone. It doesn't cost the insurer any money. The insurer pays the same amount. I think but now Congress responded to that and has put a limit on what out-of-network providers can charge. You are absolutely right that there's no excuse for not having a very clear list. One potential difference is that there's so much fluidity in the US. There's so much change about in-network, out-of-network, that you'd have to virtually hire someone to be full-time changing. I think that's an obligation. I think that this has been a scandal of these large out-of-network bills. I have no problem with what you described about Georgia. That's the right way to do it. There's a list. And what I would argue is that the duty, the obligation is on the insurer to have that list, to maintain it. And if they haven't informed the patient, then they have to pay the out-of-network provider. That would be the way to resolve this. If my health insurer has to pay you because you weren't in the network, then there's a real incentive to make sure that the patient knows. In any event, it shouldn't be the patient's responsibility. It's just too complex. It assumes, of course, that every patient has access to the internet, knows how to use it, knows how to manage the system. And so I go back to one of my early statements. The US is a very difficult system for the average patient to navigate. And your example proves that.
Yeah.
Good point. Thank you.
Okay, thank you for answering my question.
Sure. Okay, whoops, go back. All right. So so now I want to talk about the structure of the system in a little more detail. So we have hospitals and / health systems. So more and more hospitals are now being combined into larger health systems where the overall corporate body owns maybe, let's say, Trinity Healthcare has now about, I want to say, 40 hospitals in several states. They may own some nursing homes, they may own some rehab facilities, they could have home health. You just have, that's what we call vertical integration. That is, you have different types of health organizations all under the same corporate structure. And it's a system, it's a health system. There are efficiencies for purchasing supplies, building supply chains, monitoring quality across the system, but it's all about generating revenue. The larger the system, the greater the revenue. But you can start to see when you have that kind of consolidation, what's the next natural step? You buy physicians. So I employ you instead of what up until now, it's a little history. Physicians have been largely independent of hospitals and health system, larger health systems. Hospitals have been what economists have called the doctors' workshops, where the doctors are what we call independent contractors. So let's say I own, I'm the CEO of the Jacobson health system, and I want to contract with Dr. Sorry, I need my other glasses. Dr. Galetiani. I want to contract with Dr. Galetiani.
Yeah, sorry, my microphone was muted.
Yeah. Yeah, and Dr. Reno and Dr. Caval. They have, let's say, a primary care practice. I need primary care physicians. I'm contracting with you. I pay you on either a per patient basis or a per procedure, whatever we agree to do it within the fee-for-service system, but you are independent. Now, it's harder and harder for you to, because I'm now part of a larger system, I want you under my aegis. I want you to be employees. I'm no longer going to contract you because Drs. Khan and Valmiki are willing to be employees, and they're just as good as you are. Or maybe they're not as good, but they're good enough.
Mm-hmm.
And where does that leave you? It leaves you without a patient base. It leaves you without a hospital to refer your patients to. So you have no choice but to take my offer that's less than you were making before. It's a fundamental change in the power balance between physicians. For most of the existence of modern healthcare, let's say post-World War II healthcare, physicians dominated the system. Physicians controlled what was done in a hospital, how it was done. We're moving away from that. The control has shifted to the large healthcare systems, and you're now more and more an employee. You're still making a good living, but you're no longer an independent practitioner. So it's a fundamentally different way of thinking about the world. Many young people, by the way, in the US are quite comfortable with that because they don't want the life, they want a better life, work-life balance than most physicians of my age and Dr. Stein, so I'll leave him to comment whether he agrees with that or not. We're willing to sacrifice the work-life balance in favor of the profession.
I can comment that Dr. Bernard calls himself a dinosaur or a fossil, and he works essentially 12 hours a day, 6 days a week, and he's the old-fashioned doctor, which in reality, there's no life. There's no life after he gets finished every day. And since he works on Saturdays, there's a little bit of life on Sundays, but most young people would not want to do what he does.
Right. So that's a little misleading. I should have put what you're getting now in healthcare is physicians are, sorry, I don't know what's happening. Doing a couple things. One, they're building independent practice associations, IPAs. They're usually multi-specialty and either operating their own clinics, doctor-owned clinics, doctor-owned hospitals, or becoming employees. The hospitals are buying up the individual practice associations, buying up the multi-specialty, buying the multi-specialty clinic. So you still operate, you still have control, but you're under a larger corporate organization. Palo Alto Medical Clinic, as an example. I think it's now part of Stanford. When I interviewed on a project there, it was an independent, freestanding, doctor-owned medical clinic, multi-specialty clinic. But for all the reasons we've been talking about, it's just harder and harder to maintain that independence. Then we have hospitals, health systems. We also have what we call managed care organizations. I've alluded to that. Kaiser Permanente is the original managed care or prepaid. I pay a per month premium, and my wife pays that also. We pay a set amount. Now we are Medicare, now primary Medicare. So our premium is lower than someone your age. You would pay more, but you would still get all of your care. It combines the insurance and healthcare delivery functions into one entity. That's the difference between managed care and the freestanding employer-based insurance arrangement where I buy commercial insurance. Because there, the insurance is separate from the care delivery. I use the insurance to buy primary care, to buy specialty care. Different. In a managed care organization, the insurance and healthcare delivery functions are combined. We also call them health maintenance organizations, but I think managed care is a better. The benefit of managed care is all of my data are contained within the system. If, let's say Dr. Stein's my primary care physician, he has access to all of my data. He refers me to Dr. Neo Friedov for neurological care. He refers me to Dr. Gregorian for, or my wife to, for OBGYN care. And that records just every time I go, I get, let's say, an eye exam. Dr. Stein, my primary care, just has access to all of that. You avoid the fragmentation. It's much more coordinated. So the organization is more sort of how health services are organized. At the top, we have academic medical centers with the highest technological care, the most complex patients. Then tertiary hospitals providing very high levels of inpatient care. Community hospitals that will often refer patients to tertiary hospitals. Community hospitals tend to be nonprofits. They tend to be smaller than the tertiary hospitals. They offer less intensive care than a tertiary hospital. Then primary care is what the Affordable Care Act does is it tries to get more people access to primary care. I've argued in previous writing that we need to think of a new specialty for primary care physicians and expand most primary care practice to non-physician practitioners, nurse practitioners, physician assistants in particular, because studies show that they can provide a good 80% of primary care needs. For pediatric care, we went to the nurse practitioner all the time. For if something, a child had a more complex need, then we would go see the doctor. Same thing, the nurse practitioner, physician assistant can identify a complex care need and then refer it to the doctor. That way we can expand primary care to more people, and then the public healthcare system takes care of health promotion. So we've talked about health systems already, or what we call integrated delivery systems, where we have clinical and administrative integration. That can be integrated horizontally, multiple hospitals, horizontal, the same type of product, multiple hospitals, multiple outpatient facilities. The concern about horizontal integration is that it eliminates competition. Remember my earlier example about the new machine that are two physicians running hospitals in the same area. In theory, they should compete on price and quality. In reality, the consolidation, the integration of multiple hospitals eliminates competition. As a result, prices go up because the integrated facility or system has greater negotiating leverage with the health insurer. And the health insurer, remember, is a function of the employment system, and instead of lowering costs, the employer simply passes the cost on to the employee in the form of a higher premium, less coverage, but the leverage shifts to the integrated facility. The insurer has no choice because the employer demands that his or her employees have access to that system. Hence the higher cost. Now the vertical integration, the up and down, adding hospitals to rehab, post-acute care, and long-term care sometimes is less of a problem because the vertical integration doesn't affect costs in the same way as horizontal integration. Does that make sense? Are you following? Do you need? Let's see.
Dr. Jacobson.
Yes.
I have one question, but it's regarding the previous slide. When you spoke about expansion of primary care and how nurse practitioners and physician assistants can help in that matter. So I'm not well acquainted with US medical healthcare, but I'm frequently surfing the internet. There are multiple forums, and one of them is Reddit, which is very popular apparently in US. And on that platform, multiple residents, like physician residents, and also the attendings themselves are complaining about this integration of nurse practitioners and PAs, because they say that this results in their down pays and that they have to work longer hours when NPs and PAs are getting the equal or better pay in much less hours that they spend with the patients.
Okay.
So I don't know whether that is true or not, but that is just what I've read, and I was always interested in this part of how do NPs and PAs integrate into this healthcare system.
Great question. So the cynic would say the physicians who are complaining because they're getting less money.
Yeah.
And they're losing power. In reality, so I should back up. Many years ago, I conducted a study of the primary care roles of nurse practitioners and physician assistants. So I have a bias. I came away being very impressed with the care provided. And as I mentioned, we use the NP all the time for pediatric care. So I'm a long-term believer. It seems to me that it's not accurate that the NPs are paid more. I'm not, I'm certainly not aware. I know that when I conducted the study, which admittedly is 20 years ago, and I've followed the literature since then, but I haven't been in the field on this. One of the reasons for the expansion of NPs and PAs was that they are lower cost. There are two advantages if you're an executive. One is that they cost less, and two, they provide a different type of care. Nurse practitioners in particular are trained to provide holistic care. PAs tend to be more procedure oriented, but what I found in my study, my colleagues and I, and others have found is that NPs and PAs are pretty interchangeable, and they provide a pretty similar level of care. The legitimate concern physicians have expressed was that they're not physicians, and they will miss signs of complex care needs. That, I think, is the most legitimate objection to the expansion. At the same time, the studies have shown, as I alluded to, that NPs can provide 80% of primary care needs without any problems.
Okay.
So the question is, how do we view that delta of 20%? And in here, what we found in our study, and I've no reason to believe it has changed, is that two factors. One, the more integrated the system, that is, the more like a managed care system, the more independent NPs and PAs are. So within a managed care system, you'll have more NPs and PAs. Outside of it, you'll have less. The second thing is, and probably more important, the longer the relationship between the physician and the NP or PA, the more trust the physician has in the NP and PA, because you build this relationship of the NP knowing when he or she needs to bring in the physician to avoid that problem of a misdiagnosis. And so when I was talking about establishing a new primary care role for physicians, that's what I had in mind. That the physician would be providing care to more complex patient needs, someone, let's say, with several comorbidities, where you can't expect an NP or PA to be as knowledgeable about it. So in sum, to me, the legitimate objection is that the NP or PA is not a physician and can miss something. I'm not all moved by the sense of loss of power, loss of income, though I don't want to be glib about it. But but I think that there's a way of handling it. But I just don't, I can't imagine that an NP is paid more than a physician anywhere. Good, thank you. Good. Any other questions, comments? No?
Well, the physician
Yeah,
would have to have many more patients in the program to make sure that he's seeing enough to make a living, you know? I mean, the issue is if the nurse practitioners treat 80% of the patients, then that 20% has to be expanded in some way so the physician earns his living.
well, right, in a managed care system, that's not going to be likely to be a problem. I do think that we have the incentives upside down. We pay no offense to the psychiatric profession or other specialties. We have overpaid radiologists and surgeons for years, and we underpay primary care physicians. And look, I haven't had neurological issues, and I damn well want a highly trained physician if I do. And yes, they should definitely be paid more, but it seems to me that it's been out of balance. And from a system-wide, even countrywide perspective, what we want to do is rebuild a robust primary care system with adequate reimbursement so that you prevent a lot of these needs. And you then, specialists will get paid more, will still, because of the number of patients, make an excellent living.
Is there money now going in to promote primary care?
There is more. There's more of a recognition, but it's slow. And I think what Dr. Galentiani was mentioning is an example of that. At least there's a perception that primary care practitioners, and in your question, the way you frame your point, that we're going to have those primary, if we're going to shift to NPs and PAs for primary care, we're going to have to look differently at the reimbursement mechanisms for primary care practitioners. Otherwise, we just won't attract primary care practitioners out of medical school. And that's a problem. So I've talked about fee-for-service medicine. That is still the dominant way of providing medical care in the US. Despite attempts to move everyone toward managed care, commercial insurance is still the primary way employers handle the employee benefits. But I must say that when I was in the private sector at the Rand Corporation in California in the 1990s, Rand had very generous benefits. And so we had the typical commercial plan. But because of the rising costs, Rand changed its model. It said, if you want commercial insurance, you're going to have to pay a lot more money. Well, it just wasn't worth it. That's when we joined Kaiser Permanente. So employers can shift the incentives, can negotiate with the unions to provide more generous coverage for if you go into managed care and you pay more for a commercial product. That's one way to move people out of the fee-for-service system and into the more cost-effective managed care system.
What is the average price people pay for commercial insurance these days?
I have no idea because I haven't been in
Hmm.
that in many years. At the University of Michigan, I basically had what we call a preferred provider organization.
Okay.
And and in the university heavily subsidized
Mhm.
my care, but it is in the thousands of dollars for a family.
I have another question.
Yeah.
A lot of people lost their jobs because of the COVID and lost their insurance, I imagine.
Mhm.
What's happened to those people?
Well, if they're eligible for Medicaid, the government insurance for low income and some unemployed people, then they'll be fine. Some states have their own programs to provide care to the indigent, the uninsured populations, and many will go without care.
Okay.
They'll be part of that uninsured. Also the Affordable Care Act. What the Affordable Care Act did was it helped expand Medicaid.
Okay.
And okay, but they're out of luck. We don't have the right system. So as I mentioned before, what we're seeing in the industry is consolidation. The consolidation goes in two forms. Again, making it very complex. You'll have a lot of what we call joint ventures between hospitals and physicians. So we'll take that multi-specialty group and we'll form a new, let's say, outpatient specialty arrangement. And let's say I'm the hospital. I will build the building, a new office building for you. You'll invest in a new outpatient surgical center. And that'll be a new integrated system, a specialty care center. It could be cardiology, it could be nuclear imaging. And so you share the risk.
Let me ask a question.
Yeah.
Most of the doctors in this program are applying for a residency in the United States.
Mhm.
And after 3 years or more, they're going to want to get a job. What should they look out for? That's really the,
So I think there are two things. And I may not be the best person to answer that question, but that's a good question. One thing is areas of opportunity. Where can you get a foothold? You may want to look at rural areas. You may not want to live for many years in a rural area, but there may be more opportunities. Inner city hospitals. You may not want to work in an inner city hospital, but there may be real opportunities, particularly for specialists. So that's one. Second, I think you want to start making contacts with others who have gone through this program and find out what their experience has been. How have they managed it? Because they're the ones who will be better than I to answer it. They'll tell you what's happening on the ground. What I can say is that the US has attracted foreign medical grads forever. But you need to understand that right now we're in another anti-immigrant era. I don't like it. Some of my best students were from many of your countries, but that's the fact. And you need to keep that in mind, that the opportunities that might have been available 10 years ago might be harder to come by at this point. But I would say really look for those opportunities that give you an opportunity to establish yourself, to establish a reputation, to get the necessary papers to be able to stay over the long term, and then make your move to where you want to be. Join the specialty society. Follow what are their experiences? How are they helping people? What kind of network? Attend conferences. Try to speak at conferences so that you get known. So try to write if you are research oriented. What are the skills? What can you sell to an academic medical center, to a new group? Look for groups that are hiring. So just looking at this chart, where are the new opportunities where physicians are collaborating with hospitals? What can you bring to that? How do you get an entree to them? People like Dr. Stein, other people in this program can perhaps make some introductions.
That's great. You got past your time. Okay, you want to keep continuing?
Well, yeah. Let me just, if you want, I want to at least get to a natural break point.
Okay, please. No
Is that
problem.
okay?
Yep.
Yeah. All right. So hospitals, most are still nonprofit. Some are investor owned, and I've talked a lot about that. There are standalone hospitals are increasingly under pressure to join multi-hospital systems. It is hard now for a community hospital to remain independent. And we see this in Michigan, where we'll end up probably with 3 healthcare systems. One affiliated with the University of Michigan, one with Spectrum in Grand Rapids, and now Beaumont, which would have been a 4th, is now affiliating with Spectrum, and then Henry Ford in Detroit. And that's going to be replicated across the country. As I mentioned before, Trinity, which is located in Michigan, just outside of Ann Arbor, Novi, is a multi-hospital system. So if you're operating a hospital in Michigan, in let's say Jackson, which is a small city about a half-hour outside of Ann Arbor, you're already looking, or even a larger system in Lansing, the capital, Sparrow or McLaren, you're starting now to look for who do you want to affiliate with? Spectrum, University of Michigan, Henry Ford, because your long-term survivability is not good. Your board is going to start to say, what's your plan for sustainability? In the hospital, there tends to be a separation of the hospital administrators and the medical staff. And that's because of licensure. And you need a license to practice medicine in every state in the country. And the old model, and what inhibited the development and expansion of managed care, was you can't have non-medical people, the administrators, making medical decisions. Guess what? That model is completely broken. We honor it in structure, but not in reality. In reality, it's a negotiation between, let's say, the Kaiser Medical Group and the Permanente Administrator. That's the reality in Kaiser, is that it's not clear that you may not be in total control of your medical decisions. When you were an independent contractor, you had full control. What you prescribe is what the insurer paid for. Now, the insurer may not authorize it. Now, the hospital administrator may not give you the medical equipment that you want. There are subtle ways. The administrator and the insurer may say, no, you have to discharge Jacobson sooner than you'd like. Oh, and by the way, you may be sued if there's an adverse outcome. We may also, but we're willing to take the risk. Now, in fairness, sometimes the hospital will simply can't think of the word I want, but will take responsibility, and the physician will not be part of the litigation. But this is an ongoing issue for physicians. We do have a set of public hospitals providing acute care. The Veterans Administration. In response, well, actually, I'm not sure of this. The Indian Health Services. There are public hospitals in New York City. They tend to take all of their population is uninsured. Some Medicaid, but mainly it's revenue that the state of New York and the city of New York will provide. And that's how people who are uninsured get care. And then we have academic medical centers that are teaching hospitals. So that's where you'll go largely for your residency, into academic medical centers. I don't know if that's entirely true, but generally that's in the US how internships and residency programs are run out of academic centers or hospitals affiliated with academic medical centers. And there are specialty facilities that I already mentioned, the physician-owned specialty hospitals. There are separate children's hospitals at the University of Michigan. It's the Mott Children's Hospital. There's the National Children's Hospital at MedStar in the National Medical Center in Washington, DC. Okay, so quickly, because my voice is starting to go and I have another class tonight. Why don't we stop there?
Okay.
Marty, and if you want, I'm happy to come back for another session to finish up
Okay.
with
Why don't you
this.
stop you, unshare your screen so we can see you, okay? Okay. Well, fantastic presentation. So much, I didn't know it was that difficult. Crazy system.
Yeah.
So welcome to the US healthcare system. Any questions, concerns, or are you going crazy?
First of all, thank you for organizing this event, Dr. Stein, and thank you, Dr. Jacobson, for such a great presentation, because for us who are just going to come into US and be part of the system, it really means a lot to have this one concise material to get to know the system, because we are given some resources and materials which piece by piece explain the system, but not as a whole, like to see the big picture. Thank you for doing this. This
Thank
was really
you.
great.
My pleasure.
There'll be a quiz next time, so make sure you ask any questions you want, because there'll be a quiz, which will grade you on.
But again, I'm happy to come back and finish up
Great.
if you want. If not, that's fine too. It's been a pleasure meeting you. Thanks for your great questions. And feel free to pass any questions you have along to Dr. Stein. Happy to answer them.
Great, I can do that, yeah. Well, thanks again. Thank you so
Okay.
much.
Thank you again.
Okay.
Thank you.
Bye.
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 Thank you.
Okay,
This is still recording, by the way.
I know, I'm trying to stop it.
Okay.
Okay.